I'm a public health physician with specialization in health policy and management. Perhaps that's why they say, okay, I should talk about policy and systems. I'm looking at the audience, this ICT Alliance, so we relate it to how it has to do with what the interest of this group is. So let me begin with, I'll speak for like 20 minutes plus, then, but it has to be interactive. Feel free at any point to stop, and we just interact, share knowledge as well. I don't pretend to be more knowledgeable than everybody here, so some of you will actually be more knowledgeable than me in some of the areas. So the National Health Act 2014, how many of us know about it? Raise your hand if you've heard about National Health Act 2014. Only Mr. President. And okay. Yes, wow. If you've not heard about National Health Act 2014, kindly raise your hand. You never heard about it. Okay, fantastic. So this topic is relevant. Thank you, Project Pinto and NCS, National Action on Sugar Reduction. I'm also part of the coalition, and I was privileged to be a consultant that helped to put the group together, the National Action on Sugar Reduction, working with Gatefield and the GHAI, the partners and all of that. So focus is largely on sugar reduction, but the National Health Act provides a legislative framework, a policy framework right now for health in Nigeria. So the law of Nigeria that provides a framework for the health system. So it took 10 years to get it passed. It was introduced in 2004. It was passed for the first time in 2011, shortly before handover, and many Nigerian women had to march in front of the National Assembly, threatening to go naked if the law wasn't passed. And within a couple of days, the National Assembly passed it. Unfortunately, it wasn't signed into law because of certain opposition. Some persons who were twisting some components of the law, and deceiving the public. So, based on the procedures at the National Assembly, which makes laws for the federal government, state assemblies make for state governments, it has to start afresh after it, by June 2011. Thankfully, in 2014, it became law, and President Goodluck Jonathan signed it. So that's why it has 2014. In legislative frameworks, the dates, the year it's passed always come. That's 1999 Constitution. That was when it became law. So that's why National Health Act 2014, is there. So it's been 8 years now since it became a legislative framework. So it created our health system. And in Section 1 and Section 2 of the National Health Act 2014, if you Google it, you may even find a copy online and download. So created the health system and listed the components of the health system. So does anyone have an idea of what our health system is made up of? The health system of Nigeria. Just if you make a guess. Whoever wants to try? Okay, I promise to give extra popcorn. Okay. So the health system, you have the Federal Ministry of Health at the federal level. You have, and it has many agencies and parastatals. You have the State Ministries of Health, 36, and FCT, Health and Human Services Secretariat, is also part of it. You have the local government health authorities, 774 of them, or the departments of health at the local government level. You also have the World Health System, WARD, the political words. So the World Health System before 2014, we have up to the local governments. There's no law or policy in Nigeria that recognized specifically the World Health Systems. But the National Health Act, made that possible. So at the world level, you have World Development Committees or World Health Committees. So that's part of our health system. At the village level, we have the Village Health Committees or the Village Development Committees. That's part of our health system. Then you also have the private sector health practitioners, the alternative medicine practitioners. Of course, when you talk about private sector, it includes both private hospitals, private pharmaceutical companies, patent medicine vendors, or the chemists, as we usually call them, at the local level. You have even the alternate medical practitioners, the traditional medical practitioners. And the Federal Ministry of Health actually has a department, on trado medicine. So these are all components of the health system. And the National Health Act went ahead to create a number of technical committees at the tertiary health institution, tertiary health committees. You also have in section 11, the Basic Healthcare Provision Fund. Who has heard about the Basic Healthcare Provision Fund? Have you ever heard about it? Okay, almost the same. Okay, so say Basic Healthcare Provision Fund. Say after me. So let me not sound like a preacher. Say after me. Basic Healthcare Provision Fund. Okay, why I say you should say it, because I want you to repeat it, and I want that to sing, because that is a fund that concerns all of us. The Basic Healthcare Provision Fund, Section 11 of the National Health Act, says that every year in our national budget, the federal government should make available not less than 1% of the consolidated revenue fund of the federal government. He said not less than 1, it means it can be 20%, but not less than 1%. Usually people say 1%. No, it's not less than 1%. So it can be much more than that, to support primary health care. So that fund is complementary. It's not a replacement fund to support, not the only fund for primary health care. Because the responsibility of primary health care is with which tier of government? Federal or state?
State.
If you say federal, raise your hand. Primary health care. Whose primary responsibility is it? Federal? Yes, 1. If you say state, raise your hand. Okay, 1, 2. Okay, so it's state actually, and state has to do with state and local governments. So that's on national level. Federal provides support. Okay, so just have this additional money and support what you're doing. 50%, half of it should go into health insurance. Okay, so that 50% goes to the National Health Insurance, is now authority. Is it NHIS or NHIA?
NHIA.
What is NHIA?
National Health Insurance Authority.
Okay, if you don't know, the name don't change you. It's now National Health Insurance Authority. With the new law that was signed into law this year by the president, I'm very happy about that, because in 2019, when he withheld assets, we called press conference, made a lot of push around it. So finally, the National Health Insurance Authority has come to stay. I'll speak a bit more about that later. So 50% of the Basic Healthcare Provision Funds goes into that. Then 45% goes to National Primary Healthcare Development Agency. And of course, the one that goes for health insurance from the NHIA goes to the state health insurance schemes or boards and all of that. So it's because of that Basic Healthcare Provision Fund that made states to start creating health insurance agencies. Before this fund, they were not creating it. So, but they needed to create it to be able to access the funds. So now they've all created, so the funds could be channeled to the states. But what is happening is, at the state level, the governors just, okay, it's an agency, just create so that we can get our share of the national cake. And they don't put money, their own monies there as well, in many states actually. So it's only that basic healthcare fund, but that's not the design. That money is general complementary. But what is happening, what we've observed is even some states, the monies that are supposed to be releasing for health, they are withholding it because they feel, oh, you are getting extra money from above, which defeats completely the spirit of that National Health Act that created the fund. Why I'm talking about this is these are policies we should all know about because it affects us as individual citizens. We should know that there is this money to cater for us. And what's that health insurance money for? There is this package that is called minimum package of health, right? Of healthcare services that is defined to be delivered at the primary care level. So it includes antenatal care, even up to cesarean section. People who are enrolled, who have health insurance coverage under this fund, can even get CS without paying out of pocket. Malaria treatment, testing for blood sugar, blood pressure, those basic services that have been defined. But of course, this money is not enough for the entire population. For instance, this year's budget is about 50-something billion naira. So it's not anything close to what we need to cater for our entire health. I mean, the basic healthcare fund is 50-something billion this year. So 50% of that should be 28 or thereabout. So, and that gets distributed across the 36 states and the FCT. Then 45% goes to the National Primary Healthcare Development Agency, and every state also has a primary healthcare board. So from these monies, they disburse to every ward, every political ward, they have a one health center. So when you hear about they want to make at least one primary health center fully functional, it's through these funds they are providing that support so that if they have some needs, all the selected primary healthcare centers, they have a bank account. So the OIC, officer in charge of the health center, is a signatory. The chairman of the World Development Committee, WDC, is also a signatory. So you could understand that World Health System that is created by the National Health Act, there's a responsibility now. And they are the ones to provide oversight to the primary healthcare facilities. So at this level, there are advocacy points, because if you are talking about NCDs, I mentioned screening for blood sugar. I mentioned hypertension screening, right? Cancer screening is not part of it. Okay? So it's not part of that minimum package of health. So can we push as NCD Alliance folks for at least, even if it's examination under whatever, for cervical cancer, even if it's self-breast examination, some of these ones are not financially intensive, that doesn't require so much expertise. You can train healthcare workers at the primary care level. Can it be included so that, knowing that most NCDs, you can't really place the cost? Even as we're talking about consumption of sugar-sweetened beverages, is a risk factor, not a cost. Do we know the difference between risk factor and cost? What's the difference? Who wants to try? I had 20 years this side. No, feel free. Yes, Mary.
The risk factor is something that influences a disease that may or may not influence a disease from occurring. But a cause, is it causative or whatever? The cause is okay. Let's just assume that you're working in, they say smoking causes cancer, and you're working in a bar that has, always deep smoke. So it's definitely likely to cause, and then maybe a waiter that develops cancer. So definitely that's his job. Whatever he's doing there, the smoke he inhales causes the cancer. That's what I think. But there are, which one is the first one, sir? I had the risk factor. The risk factor might be that, okay, like for breast cancer, it may be that you have it in your lineage, my mom had, and now I am having. So those ones are real risk factors, but it doesn't mean that all my siblings that are females or male must have it. So that's how I see it.
Okay. Which style of clap? Paper clap? Tama clap? There are different types of clap. Rain clap. Okay, we are not doing training here. Okay, that's rain clap, right? What of mosquito clap? You go down, try catcher. Catch. Kill. Okay. So good trial. Risk factor speaks to probability, like you mentioned. Higher chance, could influence. There is a higher chance that persons who have the presence of a risk factor have a higher probability of having that condition as compared to those without the risk factors. Like you say, risk of something is not 100% certain. So it means if you have risk of this happening, you have to watch out for it. There is a higher chance, there is a higher probability that it could happen. But cause has a cause and effect relationship. Tobacco is not a perfect example for that. People tend to use the language interchangeably, but it's in technical language in epidemiology or research-related language. So, for cause means when you see this, you must see the effect. Okay? So, cause of burns. Something that is hot, it comes in contact with your body, it must happen. Whether it's flame, whether it's liquid, whether it's gas, as long as a certain temperature comes in contact with your body, there will be burns. Have you opened the lid of a pot that is steaming, or maybe a kettle? You carry one side, the kind of fire will come to your hand. You are not careful, you drop it and have a risk, So, cause and effect, high temperature, burns. You can't miss it, right? Okay. You see someone to be said to have malaria, you must find the Plasmodium, whatever species it is, or Plasmodium falciparum in our environment. So you cannot say this person has malaria if you are unable to show that in this person's blood, I can see Plasmodium falciparum. That's cause and effect. But risk factors is, okay, someone is smoking tobacco. The sure effect, tobacco smoking will cause. It's not everybody that smokes tobacco that have lung cancer, so it's not a cause, it's a risk factor. But to make your lungs to be dark, right? So it's a cause of, it will reduce the vital capacity of the lungs. That's the capacity of the lungs, the oxygen, those things are short. That's why you see an athlete, someone that plays football, can play 90 minutes. When the person becomes a chain smoker, he plays 20 minutes. Begin to do hand like this. Okay? So it has a cause and effect relationship because a lot of those chemicals get into the system, reduce the capacity of the lungs to absorb oxygen, so that's what we call vital capacity. So it's a cause and effect. But when it comes to like tobacco and cancer, is a risk factor. So that's why some persons will say, my grandfather smoked up to 85 years and nothing happened. He didn't have cancer. Yes, it's true. Okay, so risk factor is interpreted on the population level, not on individual level. Okay. So when someone says that, I say, yes, it's possible. It's not 100, but it's not a cause and effect. But of course, when you bring a population of smokers, let's say how many of us in this room, say we are 60. Okay, so, and we are non-smokers. Then you bring another population of 60 persons who share similar characteristics with us, put in another room, and you do maybe a cohort study. This one's not smoking, this one's smoking. And you followed this population for the next 50 years. And you carry out tests, checking for all sorts of diseases. So all those diseases, they tell you that tobacco is a risk factor. There is a higher chance that you see people with those diseases among that population that are smoking. Maybe this one might have cancer. This one may have another health condition, bronchitis and all of them. So, but not all of them will have all those diseases. And you also have a proportion of them that will not have anything. So, risk factor is based on studies, research, that you now see that, okay, people with this condition, there's something that is common among them. One, they have cancer, okay, there's family history, someone in the family, so it could be some genetic history. But it's not everybody that will get it. For instance, my dad had prostate cancer, right? It's a strong risk factor for me, okay, and my male siblings. But it doesn't mean all of us will have prostate cancer. But it just means we watch out more for it. Okay, so that's just about that. I deviated. But I usually like making this clarity anytime I'm within population of people that have interest in NCDs. Because in our messaging, when you tell somebody tobacco causes cancer, and the person knows the neighbor that is 87 years and smoking and has not had cancer, he's not going to believe your message. Okay? You tell somebody sugar causes diabetes, and you know someone who's been taking sugar sweetened beverages and is 80 years old and is not diabetic, forget, you don't throw away that message. So the language of messaging is key. Sugar sweetened beverage is risk factor, and even the consumption is excessive consumption. It has to be qualified. Because if taking sugar sweetened beverage causes, all of us will not get diabetes. That's the truth. We never take any sugary stuff, yeah. Sometimes people tend to sensationalize these messages, to stigmatize it. It's not, these things are even sugar cane. There are people who are not taking coke, but the amount of sugar cane they take on daily basis. Mango. They are natural, but they also have all these things. So in the messaging, you look at the audience, you look at some of these things. So like the SB tax, the idea is, okay, put this tax, WHO recommended 20%. We are doing 10 naira per liter right now, which is about 6.7%. The study shows that, okay, if it's up to 20%, it could increase the price of these beverages. And with increase in price, what happens to demand? The simple economy is demand and supply. As price is going up, so if you used to drink, maybe you use 500 naira and drink 3 bottles a day before, and now what 500 can afford is 2. It may just make your pocket go tell you truths. Or if it's only one you can afford and your income has not increased, you begin to take one. So it's just expected that increase could reduce the risk of, the possibility of excessive consumption. And it's looking at population level. Okay? So, and the more people who are not consuming it at a very high rate, the less the chances of type 2 diabetes mellitus. So that excessive consumption can lead to obesity, because what the body does is, when it takes what it needs, it stores the rest as fats. Okay? So that's why, men that drink, that have pot belly, they say in my place, have for beer. Beer tummy, right? So because beer has a lot of calories, it's made with millet, sorghum, all those stuff. The alcoholic content is just like 5%. The other things are things that you have, even a lot of sugar is in beer. It may not taste sugary, but the calories there is much. So the people that take it so many bottles every day, the body takes what it needs. It begins to store the excess this thing as fats. So inside the abdomen, omentum. Who knows the omentum? That one that is white, they call fats. So it begins to get bigger. Now and also even the abdominal muscles, in between them, you have fatty content. Then the omentum becomes larger. And they make the belly be like this. So, and it's a risk factor for obesity. And also a risk factor so it kind of over time begin to affect the capacity of the body to moderate and regulate, the sugar or the glucose in the system. And for those who may even have some genetic predisposition to diabetes and all of that, if the thing is supposed to start at the age of 45 before, if it's supposed to start at the age of 60 before, it may just start at 40 something. So some of these things, there's a lot of interaction between the environment and man. So, and the environment has to do with external environment and internal environment. And part of the internal environment is what gets into our system. So when we have these understandings, it helps in our messaging. Okay, I've used a lot of time. So let me quickly mention something else about the National Health Act. So Section 20 of the National Health Act has one provision that everybody should know about. It says that on no account should a healthcare provider refuse to provide medical care in an emergency situation. But that provision was made with certain assumptions. Part of the assumption is because the basic healthcare provision I talked about 50%, I talked about 45%. I've not talked about the 5%. 50, 45, and 5, that's 100, right? So 5% of the basic healthcare provision fund should go for emergencies. So the idea is that basic healthcare fund is not only the 1% of consolidated revenue fund. You could also have monies from donor partners, from philanthropies, from companies, and all of that. Any additional money, even government deciding to put in more money there. So 5% should go to support emergency care. So what that does is, if we have enough money in that as part of that pool of fund, a private hospital wouldn't need you to pay deposit, for instance, because private hospital is business. And people come in emergency situations, when they get better, they disappear. I'm not making assumptions. I've seen that happen. Some of my patients have disappeared. So, and imagine the hospital have given treatment worth 70,000, and that person runs away. Sometimes you see their pockets and all those inconsequential things around. Don't go early morning and just find a way. So it happens very often, and that's that behavior that now started making, because when they say, they are callous, they are wicked, I don't know human beings, you don't know their experience. Because if that keep happening, that hospital will go down to the extent that even people that have money to pay will not see hospital to attend. You know, they say now good morning, they follow how are you, and then they precede how are you or something. You know, so that assumption is okay. As the hospital owner, especially private, you will not have to be bothering about, okay, I could treat this patient and they will disappear without paying. Providing care, no question. There is monies you can claim and you'll be reimbursed from that, be the health insurance money or the emergency 5% emergency fund. But as you speak, that the use of that fund has not even been activated. And of course, the money is not enough to cater for emergencies everywhere in the country. So what the Federal Ministry of Health was planning is, okay, if it's the busy highways, we identify healthcare facilities around there, you know, have ambulance services, and also have partnership with the hospitals around Abuja, Lokoja Expressway, Kaduna, Abuja, Kano, Lagos, Ibadan, Enugu, Port Harcourt, you know, all of that. So, but plenty grammar, no action yet in that regard. But we just need to know this so that we could be asking the right questions. So, that section 20 is what we need to know because it's a law. And if we don't test it, people will keep suffering. It has a fine of, is it 200,000 or 6 months imprisonment or both for any healthcare provider that refuses to attend to emergencies. Okay? So, there's also a certain provision of certificate of standards. The National Health has said within 2 years of the Act, every healthcare facility, whether it's for research, whether it's for patient care, whether it's for training, must have a certificate of standard. The Federal Ministry of Health was supposed to develop the standards, you know, of course, at the state level, the State Ministry of Health for that, you know, and they show that every health facility meets that standard and they'll give a certificate so that when you enter the building, you could see, okay, this facility is certified to have met basic standard. This is 8 years after the Act, it hasn't been implemented. Even though the Act gave 2 years of grace for that provision to be implemented. So what that means is no single health facility in Nigeria by law is of standard. It's a matter of law, you know, so it's not an optional thing. So these are also the kind of things, maybe because there's no money involved. Basic healthcare provision fund, every time we're hearing about it, everybody is fighting because money there involved, billions of naira, you know. So, but the other ones that monies are not involved, it doesn't get lots of attention and people don't get to know much about it. So, I spent a lot of time on National Health Act because it's the parent law for health in the country. But you also have the Tobacco Control Act. You know, the public hearing, the last public hearing for that, I think in 2015, I was there. And of course, for those, who else was involved in the advocacy for Tobacco Control Act 2015? Okay, nobody. So that one took a while. The tobacco people, they get money and they are very strong and have a lot of groups, opposition and all of that. You know, so and the idea is, at least one of the things that was achieved is you cannot advertise tobacco again. Have you noticed that? Yes. Who knew when tobacco was being advertised? There's one, very nice music. There's one, that's forever, forever. When they finish, they just, you know, they make it look so cool. You know, targeting young people because they want something that makes them want to be a big boy, you know, to show that you've arrived, they have to be smoking. So, policy was used to stop that. You know, at least just that we don't do a lot of research in Nigeria, by now we should be able to say this is amount of consumption before this policy, this is what it is right now. So, but Tobacco Control Act is there. It's raised tax on tobacco products. It also stopped advertising. It prohibits indoor smoking and smoking in public spaces. So those clubs that they are dancing and smoking inside is against the law. It violates the Tobacco Control Act because you are making others passive smokers, right? So, and as NCDs, even for tobacco, if you're a passive smoker, your risk of health condition is even somewhat higher than that of the active smoker. And of course, that's for tobacco. Those that use firewood in the closet and all of that also have risk of COPD, chronic obstructive pulmonary diseases, especially later in life. But that's one is entirely on a different scope. So, but Tobacco Control Act exists. It's a health policy that should be of interest to those of us in NCD Alliance. There is also, of course, I mentioned the National Health Insurance Authority Act 2022. It's one of the latest health policy frameworks. So, and it has made health insurance compulsory. Every Nigerian, according to that law, every resident of Nigeria should have health insurance. We should know this. Chronic diseases are mostly NCDs, true or false? And they're also mostly expensive to manage, true or false? So major interest for NCD Alliance is financing, whether it's heart disease, whether diabetes mellitus, whether it's hypertension, whether it's cancer, whether it's kidney failure, whatever it is, very expensive to manage, and financing is key. So, Health Insurance Authority Act that now, because the principle of insurance is you have pool of funds. Let's say 60 of us there, we contributed 10,000, right? So how much would it be? Like 600K, right? So the idea is, if anyone here is sick, it's from that 600K you use to treat the person, knowing that all of us will not be sick at the same time. So it could be said, okay, maybe 5% might be sick within a year, right? 5% of 60 is 3. And you do it in such a way that, okay, let's everyone contribute 10K. So if 3 are sick, which kind of illness is common among this population? With this 600K be enough to provide so kind of treatment. So if you do the math, you just realize that with 10K, premium for that health insurance, that you cannot treat cancer. True or false? So when you have that health insurance with that small number of persons, and you say, after I have health insurance, why they are not covering cancer? You cannot cover it. Because it's Naira and Kobo. So the smaller the number, the less likely what it's going to cover. You get? Because just 600K cannot even manage one cancer condition. So, and that's why they now come and say, okay, it will cover malaria, headache, flu, all those stuff. That that, okay, with the available money you can treat. And it's from there you also make other administrative expenses that is involved in managing the funds. But when we now have 6 million people paying 10,000, okay, so the kind of money you get will be in billions or even trillions, right? So even though the 3 million is the 300,000 is the 5%, but then with the volume of money, even if you put it in fixed deposits, the kind of additional money is going to make is more. That's why pension money is making a lot of money because of the volume, right? So when we have more contributions, everybody is covered by health insurance, we have a larger pool of funds. And with the larger pool of funds, we can make more money from it. Just anything you put it at, so 0.1% interest times 6 billion. You know how many millions it will come to. Are we together? So that's the advantage. And we have to really push for it. For the implementation, there is a law now. It took a while, lots of back and forth. I know a number of meetings we held at the National Assembly, to get it passed, and the number of meetings we had to get it signed. It wasn't signed in 2019 when the 8th Assembly passed it. Thankfully, it's been signed now. And why it wasn't signed is also a money-related issue. Okay, they say, okay, there will be a tax on this in order to get more money. The finance people, this will be double taxation. There's already tax on this, so putting additional tax and all of that, the president sends it back. And again, it's created what is called Vulnerable Persons Fund. This new health insurance act. So vulnerable persons are the poorest of the poor, jobless persons, elderly people, children under 5 years, and all of that. Perhaps persons with disability. So it created a fund that the federal government is supposed to put money, state government will put money into that fund to create health insurance for people who are unable to pay premium. Of course, civil servants, they will take from source their own contributions. Artisans can, through their unions, Union of Keke Riders, Union of Rice Farmers Association of Nigeria, all those ones they can reach them, and they also it's expected everybody should have one form of health insurance or the other. So we may not just take boom, but if NCD Alliance doesn't add a voice to it, use evidence, use people's stories, the challenges with funding, many of the health conditions that comes with this, it will be challenging. The tax on sugar reduction, the idea is okay, it will reduce excessive consumption of sugar. It's also a policy. But this time around, it's not like a legislative policy, but it's an executive order from the executive, from government. But it's part of the financial tax. So that order is derived from the financial tax. No, financial act, not tax. Financial act 2020 or 2020? 2020, Financial Act 2020. So that's where, because every policy derives its power from a certain law. So that's where that is derived from, and is implementable. It may not be enough to change lifestyle or behavior, but it's a starting point, But the next thing is where is this money going to? As it is now, the money is part of Consolidated Revenue Fund. It can be used to buy biscuits for Aso Villa. Okay, or even buy sugar-sweetened beverages for government events. So next push should be, how can we isolate these monies and channel it? At least there is an NCD desk in Federal Ministry of Health. There's also cancer desk. So can we channel these monies to prevention? Can it be channeled to be part of the Basic Healthcare Provision Fund? Or can it be channeled to fund screenings at the primary healthcare level? Screening for cancer, screening for diabetes, screening for all the various forms of non-communicable diseases. So that we know that, okay, this additional money that is coming from this is also being used for prevention. Are we together? Or could it be channeled to providing equipment and tools that could be used in the management of NCPs? Different options, but we must begin to have this conversation. So I think I've used almost the time I was given. Let me summarize. I talked about National Health Act 2014. Which other policy did we talk about? Yes, I've mentioned National Health Act. Which other one? Basic Healthcare Provision Fund is a component of the National Health Act. Which other policy? Finance Act 2020. Okay, National Health Insurance Act 2022. Tobacco Control Act 2015. Okay, time will not permit me to talk about the Violence Against Persons Prohibition Act. Because that one, do you classify that as not NCD? Victims of violence. It leads into conditions, in fact, it can also cause mental health disorders, which is NCD, the trauma, rape. Rape causes mental health disorder. the trauma arising from that. In fact, the mental torment is much worse than whatever physical injuries the person might even have. So it took 13 years for that act to be passed, that Act 2015. I got actively involved in the last year of the advocacy when I led a team of, we were 32 of us that we just used social media at that time, Twitter, everywhere, harassing the hell out of, National Assembly persons, So, and they started, because they started the thing, 2002 was the first time it was presented. 2003 there was election. They didn't pass it. After 2003 election, they started afresh. It didn't become law till 2017. 2007. After election, they started afresh, So any law you didn't complete, new set of National Assembly, it will start afresh. So that was how it, 2015 was coming closer, why now? And most victims and perpetrators were young people and all of that. So I created this group I called Choice for Life Advocates. We had a number of influencers then, Buki Shonibare, Lori Supergirl, even Tolo Gulesi was the team, Francis Anyebu, we just now say, people didn't know about this act. Those who are pushing for it were doing more of, the legislative engagement, round table meeting, or drink tea, all those policy stuff. He wasn't going. So we now started supporting on social media to complement the real action. So now map the stakeholders. Who are the potential? Because when you bring up those kind of laws, people bring all sorts of things to it. In some parts of the country, people feel it's normal to be beating up their wives and all of that. So, and when you come that, they say, this law will empower their wives to be disrespecting them and all this kind of stuff. So people begin to bring a number of things. And even the rape component, the question of if someone is a victim of rape and there is pregnancy arising from that, do you keep the pregnancy or not? Given the potential health implications, especially if the person is a minor. So it's not just a case of, there's violence, there are other things that has to do with it. It started as Violence Against Women Act. Some parents say, why must it be about women? Men are also victims of violence. They changed the name to Violence Against Persons. Of course, women are more disproportionately affected. But we're happy it got passed in 2015. And in May, just a few days to Jonathan leaving office, the former president, he was able to sign it. And we're also happy that right now, at least how many states at the last count? Close to 30 states have been able to domesticate the Violence Against Persons Prohibition Act. And there's been some successful procedures. So it's also a policy, a health policy we need to know about because of the implications of violence on STDs, especially mental health situations. Any question? Or contribution?
Thank you very much. That was a very instructing and you run through almost all the acts. My question is on this National Health Act, particularly area where you talked about no account should any health facility not to render service in emergency. Now, don't think this is a trap. Now, nobody has been prosecuted on that. But going forward, because I know it can happen, it's not a trap for those when this the provisions, the addendum part of it, that the 5% are not being made available. So what happens if it happens that the hospital now refuses to render service because of non-payment, and then the hospital is not prosecuted? What do you think will happen? So that's my worry. If because nobody is talking about it now, there's no advocacy on it. even Nigerian Medical Association are becoming quiet about it. Nobody's talking about it. Maybe it could happen. Somebody could send to jail for not rendering service. So what do you think should be done by this now? Thank you.
Thank you, sir. You say non-payment. Well, payment comes after service, not before service. Right? So the assumption, the law will not make assumption that people will be responsible. So because in an emergency situation, the first thing is you want to intervene. Time is of essence. So, and it could be that people are traveling, there is an accident. That's the emergency. So it's not for cold cases. So if there is an accident, maybe someone is traveling, just have 2K in the pocket, is brought in coma, the people that brought them don't even know them. Payment doesn't even come up. Okay? So the thing is now, you have to, and that's also the same with the training, and that's why like medical training, most time we don't even know about money. Doctors don't know about money, except you are running private clinic. But like a national hospital here, they'll just tell you what to do. You go here, they'll write cost. You go another place, they'll write cost. You go where you pay. When you finish with those people and come back, the doctor will attend to you. You may not even have idea of how much you are paying for whatever. Except maybe surgeons that could say, okay, this procedure is also amount. So even the design of the training is in such a way that you don't even know much about what it's happening about. But why that provision should be challenged is something that helps to strengthen our system, right? If, for instance, a private practitioner, because in government hospitals, people have abscond, but they'll still get their salaries at the end of the month. For a private practitioner, if you begin to explain many of that, you shut down the clinic, and everybody loses. As a doctor or the owner of the place, or even if it's a midwifery clinic, a maternal clinic, when it's closed, people who can pay will come, there will be no service available. So it's even more hurtful. So if you have certain experiences and they are documented, and someone takes you for prosecution, and you're like, okay, this is the experience you had. In year 2020, you attended to 20 emergencies, 7 absconded after resuscitation. The hospital had expended over ₦1 million in managing these 7 cases, encountered it as a loss. If it continues at this rate, the hospital would shut down. It will lead to job loss, economic loss, and also unavailability of services to the other 14 who paid. So if this hospital shuts down, the 20 people that you attended to will not even have any hospital to attend to them in the first place and could lose their lives, right? So in order to save the business or the hospital to cater for those who can pay, you now came up with a policy that there must be some minimum payment before you begin to give care. It may not be a justification, right? The court may still say, no, this is not enough, you pay fine. But it will trigger a conversation. And that's why this health insurance stuff, is good. We'll now begin to say, okay, how do we, because law is meant to be implemented, but just making it and say there are factors. So how do we ensure that the 5% of basic healthcare provision fund and generally other funds to make sure that people with this experience will be able to make claims from government to get reimbursed. Okay? So even the court can even make that recommendation and make it as part of judgment to direct government to take so and so action, so as to make that section 20 implementable, especially for private healthcare practitioners. But when these laws are not tested, it just hangs there. Even many healthcare providers don't even know about it. Some people will still ask you to get doctor's reports. Meanwhile, there's a separate law, 2017 December, that the president signed it, on gunshot injuries. So if anybody asks for doctor's report, the person is breaking the law. Police report, sorry. Gunshot injury. In fact, there's never been any law in Nigeria that said there must be police reports before you attend to gunshot injuries. It was the making of overzealous law enforcement agents. They come, they will arrest the health workers, doctors and nurses, say they are accomplices to the crime, begin to extort money from them and all of that. So it's that behavior that, in order to protect themselves from harassment or being locked up for an offense they don't know about, they now started saying, okay, there must be police report. But in order to address it, that Section 20 of National Health Act had it in mind. But even after that, it wasn't enough. The National Assembly now had to make a separate law on care for gunshots, victims of gunshot injuries, Act 2017. So you can also look that up. So when someone is brought with gun, you must begin to treat to save the life. But you must report to law enforcement agents as a nurse or as a doctor to say, I have these patients with gunshot injury that I'm resuscitating. Where you breach the law is if you do not notify the law enforcement agents. But you don't need to notify them to start treating. First of all, the patient comes in, you start resuscitating. As you are stabilizing the patient, the admin people in the hospital are reaching out to, to law enforcement agents that we have a patient with gunshot, so that they can come and know whether the person's hands are clean or not. If the person's hands are not clean, they will give the proper treatment and now go to the other aspect of law enforcement. Thank you, sir, for that question. I've exhausted my time, right? Thank you for listening.